Hi, my name is Gabby, and today I'm going to be talking about the skeletal system. As an individual going into the physical therapy community, this is part of the body that I feel confident and fluent in, and I want to speak about because this is my favorite, to include bones and muscle. So, with movement and in a clinical setting and applying anatomy, um, as a future physical therapist, I will be able to diagnose and treat within a realm within my scope. So they recently updated the requirements for physical therapists, and we now have an extended curriculum into having a doctorate. So we now can diagnose, but each state will have its own regulations as far as what we can do. It's called direct access to physical therapists. I can, for the most part, within most states, treat, diagnose, treat, and begin um, within my scope. And then again, I'm required to send my evaluation and my thoughts back to the primary care physician or the specialist. And I feel like that's very broad and very general for your most standard orthopedic type of outpatient care clinics, which is what most people think of as physical therapists. But within the additional realms, although we may be able to diagnose and treat, I don't think that a majority of those are going to come from me because we are so broad and can facilitate treatment for a number of healthcare issues to include cardiovascular, pulmonary, neuro, geriatric care, wound care, and etc. So most of those are going to come from the physicians back to us. And then again, reiterating from a traditional neuro standpoint, not from neuro, sorry, excuse me, from a traditional orthopedic setting, they are the surgeons, the ones facilitating the care initially. And they're referring back to us, or they've done like a prehab thing where they've come to the clinic. I've seen that with like hip replacements or knee replacements. We meet and greet and begin a prehab, and then they come back after they've had their surgery, and then we continue. So we aren't technically diagnosing at that point, but as a physical therapist, we can diagnose and treat within our own scope, vice versa. Right? So they do the surgical portion, we facilitate treatment and diagnosis within our realm. And then so if I have a patient who's coming in and I'm evaluating them and then I'm writing up my evaluation, of course, I'm going to need to use specific medical terminology. So if I have Bill who comes in and he's had a total knee replacement, I'm going to write up his evaluation to said doctor upon supine placement, knee in full flexion or knee in partial flexion. Patient complained of medial proximal inguinal pain with external rotation of the hip or with the knee being in partial knee flexion at less than 90 degrees because they're post-op. Patient has referred pain, posterior, medial hamstrings. You could even go as far as to identify, that it might be gracilis issues if it's coming inguinal, or just keep it more hamstring areas, even though the hamstrings are made up of 3 muscles. Same thing with okay, so patient is in supine position, knee is in partial flexion, we're having additional lateral pain upon palpation, distally to lateral epicondyle or lateral condyles, anterior or posteriorly, wherever the patient is feeling the issues. If he had additional pain, more inferior and distally within the leg, so then we could talk about, upon palpation, lateral of fibular head, but still, not still, but I wouldn't word it that way. Lateral fibular head, but medial to the greater tuberosity of the tibia. That would specify that the pain was, lateral to the greater tuberosity, but medial of the fibular head. So it could be, something right in between. And vice versa, lower limb, those types of